Okay. Hi everyone. Welcome to the tag for the Cost Growth Target Program. We have a few items on our agenda today. I think we can go to the next slide, Annette. Oh, sorry, back one. Yeah, so here's our agenda for today. We're going to go through a few program updates. Then we have basically a list of suggested updates to the CGT1 data submission process for 2025, and we'll share those with you. Then we have a few updates to our CGT4 frontline workforce template that we also wanted to share. And finally, we will touch base on what we're going over for the next meeting. So I think we can go to the next slide and the next one. Program updates. So we went over this quickly last meeting as well, but we have two new committees that are being started through the Oregon Health Policy Board. The main one is the Affordability Committee, and then there's also going to be an Industry Advisory Committee. And as a reminder, this is sort of replacing the CGT Advisory Committee, but it has sort of a broader mandate to look at affordability writ large, whereas the old CGT Advisory Committee was really more specific to our program. Next slide, please. So the Affordability Committee is sort of the main committee doing the work of trying to investigate different policies that the health authority and the legislature could implement related to affordability. That committee is going to be focused in terms of its membership more on patient advocates, healthcare consumers, healthcare purchasers, and then economic and policy expertise. But the Health Policy Board decided that they didn't want to, they wanted to make sure that they had input of industry experts as well. So there's going to be a separate industry advisory committee that is working with the Affordability Committee and advising them on their work. And that membership is going to be more focused on different industry actors, such as commercial health plans, Medicare Advantage health plans, providers of various sorts, et cetera. You can see the list on the slide here on the right. All members of each committee have to have a demonstrated commitment to affordability. And next slide, please. All of this is just to say that we started committee recruitment. So recruitment for these committees is ongoing. It started up just a week or two ago. And there's another week and a half or so to submit an application. Obviously, most of the folks on this call would be probably good candidates for the Industry Advisory Committee. So we definitely encourage you to look into it. Let me share I'm going to just share the link for the application in the chat. Okay. Does anyone have any questions on the new committees that are coming up? I will take that as a no, but we hope to have some of you submit applications for the Industry Advisory Committee in particular. Next slide, please. So the next program update is just a reminder that we are going to have our annual cost growth target public hearing. That hearing is going to happen June 10th this year. And similar to last year, it'll be hosted by the Oregon Health Policy Board. Format is TBD, but it will likely be a hybrid virtual and in-person meeting, similar to what we did last year. Next slide, please. This is just a quick update on cost growth target data validation at the provider level. A lot of you know that we've been meeting with provider groups the last month or two. This year, we have 54 provider organizations that were identified for participation in the program based on the number of member months that were attributed to them. So far, we have met with 34 organizations out of the 54, and we just have a few left with scheduled meetings. And around 20 provider organizations have completed validation. The next step for all of this will be for us to contact provider organizations about reasonableness conversations if you're over the target with statistical confidence. And we are going to ask you for that meeting. We haven't sent any invites out to provider organizations yet. So don't be surprised if you haven't received anything. But we're hoping to wrap up validation in the next few weeks and send out those notifications about whether we are requiring reasonableness meetings for each organization. Does anyone have any questions on the last couple of updates?
Margaret, this is Blaine from Neighborhood.
Mm-hmm.
I'm thinking that we would already know if we were going to be getting one of those letters because we got our performance of whether we met or not. Is that correct?
Yeah, so the main thing is if you were not over the target with statistical confidence, so if like your cover page said either indeterminate or met the target for the year, then you can assume that you won't have a reasonableness meeting. There are folks who were over the target with statistical confidence. Most of them will probably have a reasonableness meeting. Some of them might not, just based on OHA's initial review of the data. Occasionally, we're able to identify an acceptable reason for growth without having that meeting. And we want to save everyone some time if it's not necessary to have a meeting. But yeah, if you were not over the target this year, you will get a notification, but it'll just say you're not over the target. You don't have to meet. You're done for this year.
Got it.
Does that
Thank
help? Yeah. Um, okay, great. Next slide. Okay, so this is kind of our main agenda item for today. Every year before we have our annual data collection of this Costco target data, so that's the data that is showing whether where you are in the target, total medical expenses, et cetera. We usually take some time to review our manual and our template and see if there are any changes that we want to make for the coming data submission. This year, I believe the data submission for 2025 will be due from payers around September 5th, which should be the first Friday in September, I believe. Yeah, so September 5th, it might be the first Monday. Anyways, it is September 5th. That's when the data will be due this year. But we want to have the data manual and the template updated well before that, so you can integrate that into your data pool for this year. So the process that we're going to follow for this, which is similar to what we've done in previous years, is do sort of an initial share out of the ideas that we have. And that's just based on ideas we might have noted down during having conversations with payers and providers this year and throughout the validation process. We're making some changes related to policy changes that happened and new types of payments through Medicaid that came online in the period, et cetera. So this meeting, we're going to be sharing out those ideas. Between this meeting and next meeting, we will do an actual draft update to the manual and the template, and we'll share those out with everyone. And then at the next meeting, hopefully folks will have had a little bit of a chance to look over the updated materials and come with any questions. And of course, some of the ideas that we have today may or may not be implemented. So that'll give you an idea of what we're actually planning to do. And then after the April meeting, we can finalize things and be ready for just sort of prepping for the next data cycle. Any questions on the process? Okay. So with that, I guess we're just going to go through the suggested changes that we had for this year. I'm going to hand it over to Sam for the next two slides, I believe. So Annette, you can go to the next slide. Thanks.
Thanks, Margaret. So I think one of our first suggested changes this year isn't a big one, and it's about the attribution and how the tiering happens. So we're not changing the tiering. The tier one, tier two, tier three are all going to stay the same. Where tier one is member selection, tier two is contractual arrangements. However, I don't think we've been very clear in the past about exactly how a member gets into each of those. We kind of just assumed, but we want to nail that down a little bit more. And those times when a member is automatically assigned a PCP because of contractual arrangements, that should be classified under tier two and not tier one. So if a member like comes in and actually selects, like makes a specific PCP selection, that is the only person that should be in tier one. All others in those contractual arrangements should be in tier two. I think that makes sense. And this is mostly, it's not really going to affect the payers, but it does affect the providers and how they understand who's in each tier. So it can be helpful kind of down the line. Um, are there any questions about that specific bullet point? Hearing none. The second one is also about not really going to affect the payers that much. It's mostly about the providers. And even further, it's really about these IPAs that we've been trying to get our hands around a little bit more and understand. I think we're starting to understand them a little bit better. This past year, we added this column for IPAs or contracting organizations if it was applicable. Um, and the applicability is still going to be there. If it's applicable, we want that information. Whereas last year we made it optional. This year we really do want to like hear about who those organizations are, hear who those big players are, and so we can get in a room with them and understand like just how much impact they're having. So we're gonna mandate that column to be filled out if you can fill it out, or if it's relevant to the specific you know reporting year and line of business and that specific provider that you're attributing data to. So we had some payers do it last year. It didn't seem that painful. But like it wasn't, not everybody had to do it. So this year we're gonna kind of expand that horizon a little bit, and we're gonna expect a lot more out of that column so that we can meet with some of those IPAs a little bit more successfully. Are there any questions about that column and what we're expecting?
Just to add, I'm kind of just curious about like the feasibility of being able to do that. I think we've had maybe kind of a range of abilities across payers. The idea is that if you have a contract with an IPA or some total cost of care contract that involves working with multiple provider organizations, we would want you to be able to split out the costs both given to the IPA and sort of actually allocated to the individual provider organizations taking part in that. Yeah, so I mean, just to highlight, I don't know if there are some payers who are more able to do that than others. Curious if there's anyone who looks at this and is like, no, I can't do that. What are you talking about? Which obviously we can't mandate it if you can't do it, but you know, just trying to get a read of the room if anyone has thoughts.
And if you need to think about it a little bit and think about like take it back to your teams, we'll take your comments, anytime, and we'll probably talk about this again in an upcoming meeting. But I just wanted to get everybody thinking about that. Let's go on to the next slide. And this one's specifically for our Medicaid payers. So health-related social needs are new in 2024. It was the end of 2024, but it is going to be a new benefit that was specific to Medicaid CCOs. And so HRSN as a category is going to have to be considered going forward, and we're wanting to get ahead of it, and we're wanting to add a claims category for HRSN specifically. This would only be used for our Medicaid CCOs to compartmentalize the claims that are HRSN. Um, and we really just kind of want to talk about the feasibility of that. I think it's feasible. I've talked to our HRSN team. It sounds like there are claim categories set up to be used for this specific service, but what I don't know if there are non-claims categories or non-claims dollars that are going to be significant enough that we need to set up a non-claims category for HRSN. Um, and I just kind of want to hear about the ability to identify HRSN claims. I'm expecting that you should be able to do it. And so this will be our plan unless there are some big hiccups that we don't know about in your processes. So are there any CCOs here that can comment on HRSN if you've had to capture those claims, if you're familiar with them, and if they're all in claims, or if there's some that do not flow through the claims side of
This is
things?
Byron with HealthShare.
Yeah.
We have not been allowed to start submitting HRSN through the claims system. Everything has been non-claims and very little money has actually been coming from the state. They haven't paid for any claims for us. I don't know if any other CCOs are further along in that process, but we will have no HRSN claims in 2024. We will have non-claims that we're working on estimating from our partners, and we're submitted on the L and submitted on a settlement template in September, and that may be able to end up in non-claims columns. But I wonder if the claims discussion should be kicked a year. In theory, it might start flowing this year in 25, but we don't have a lot of visibility on that.
This is Larry from YCCO. I think you're going to need both for 2024 because there was an 8/1 start date for claims being submitted, but anything prior to 8/1 for all CCOs is likely going to be non-claims.
Okay. Larry, is it the same as you? Like you can identify, like what non-claims are, and you'd be able to separate them because you already have to kind of do it for the Exhibit L reporting?
Exactly. That's the
Okay.
supplemental that Byron mentioned. We all had to submit that obviously, so for pre-8/1 for reimbursement. So
Mhm.
we'd have that for the non-claims.
Okay. Yeah, in talking with our HRSN program folks, maybe we're more capable, they were talking more about claims within the system and like actually being able to process them and have places where they can exist, but maybe not being able to accept them is a whole different process, and they're not quite ready for that yet. So it sounds like, okay, we'll maybe not keep an HRSN claims category this year since it doesn't sound like you would even be able to use it. But HRSN on the non-claim side, it is something we want to break out because we're not sure about the size of it. We're not sure about how much money is going to be flowing through there. And it'd just be nice to break it out and not um, have to do that on the back end, essentially. We can just do it right off the bat. And for those CCOs who have been paying HRSN, um, you're not paying it to, you're paying it, these are new providers, like HRSN provider is going to be a non-standard provider, I assume, that you're going to be paying that money to. And so there's no threat of those dollars being attributed to any providers would be my next question. Like any primary care providers, rather. I'm worried about downstream effects. So when we're talking to one of our PCP clinics, I would expect that they're not really in the HRSN game, and so they shouldn't have any dollars associated with them in that space. And I just want to make sure that that is actually the case. But those dollars are they attached to, I'm just going to jump to my next question. Are they attached to a person who would then be attributed to a PCP potentially? Can you attribute those non-claims dollars to a member?
Theoretically, yes. I mean, if you've got the claim and you got the member ID, you'd be able to attribute in that manner just fine. As far as attribution of the cost, about who for the cost or ordered the cost, I mean, there's potential PCPs could be referring for certain services. I mean,
Okay.
ideally, you want that aspect of it. So that kind of gets tricky on whether or not do you attribute those costs to the clinics or not. And the other intermingling is you're going to have CCOs showing up as the rendering provider in some of these claims too, since we're helping administer the benefit.
And where would the rendering provider, how would that affect the submission for cost growth target? Is it going to be um, in the actual PCP attribution side, or where does that occur?
It shouldn't come into play,
Okay,
in my
good.
opinion, but I could be wrong.
So it's okay if these dollars are attached to a person who is attributed to who has a PCP attribution. That's fine. I just wanted to make sure that no new providers were going to be popped up and they're not hitting your logic as a potential PCP. There are those utilization algorithms that could think that, oh, this is an organization, then this new HRSN organization is a potential PCP, and that is obviously not going to be the case for us. So just wanted to double check and hammer that home. And it sounds like we have maybe a slight tweak here where we're not going to have claims, we are going to have non-claims for HRSN, and I think that would be fine. And if you all go back and think about this a little bit harder, that's totally fine. We'll take your comments and figure out how to make sure we get this HRSN part down pat. Okay, I don't think I hear anything else. So let's go on to the next slide.
Okay, thanks, Sam. Okay, I'm gonna go over the next item. This relates to some changes that we're considering making in our non-claims subcategories breakout. And this is coming, basically, we had an interstate working group this year that was convened by the Milbank Peterson Foundation. Through the group, they had all of the Costco target states come together and try to think through, is there some way that we can kind of align our methodologies to a certain extent? So it might make it easier for some of the national payers to submit data. It might also make our data more easy to combine across states and do sort of comparative analyses. So one of the topics that we looked at was what categories everyone is using for non-claims. And the recommendation that the group came up with was slightly different, although fairly similar to Oregon's pre-existing categories. And the team reviewed the final recommendations from that group and kind of agreed that they might be a bit more logical and useful than the categories that we currently have. Again, just with some minor updates. So there's basically just a couple of changes. The first one is that we're going to just sort of update our definition of non-claims recoveries and clarify a bit that any information included in that category that should be recoveries against non-claims. So anytime that you have a claims-based recovery where the payment was initially made through the claim system and then recovered later, maybe due to an audit or something along those lines, we're going to clarify that those recoveries should just be netted out of the corresponding claims category. Then secondly, we are also just going to clarify that non-claims recoveries shouldn't include shared risk settlements, which may not have been 100% clear from the current definition that we have. Does anyone have any questions about that one? Okay. The other change that's a little broader, is that we haven't really found a lot of usage of the provider salaries subcategory. I think that category was used a bit less than we thought originally. So we're going to get rid of the provider salaries subcategory and anything that was in provider salaries previously. I guess we hadn't really discussed this amongst ourselves, but I'm assuming you'll just be able to put that into non-claims other at this point. So we'll get rid of that subcategory and then split the performance incentives category into two separate categories. Category 1 is just performance payments, payments made to providers based on their performance on specific metrics, which could be related to quality of care, patient outcomes, or other data reporting. And then category 2 is going to split out shared savings versus and shared risk settlements. So, there might be some sort of quality aspect to that, but the distinction is the shared risk and the shared savings between the payer provider. So financial arrangements where providers are rewarded for achieving cost savings and or quality goals for a defined set of services over a specified period. I think if we can go to the next slide, Annette, this is just kind of a follow-up to visualize those changes. So this is what we're considering on the going from the categories that we currently have on the left to the categories on the right. Does anyone have any feedback or thoughts on this suggestion?
Can I ask a question on the performance incentives? Sometimes we're not able to delineate between, like, it's a combination of those two items. And so would you default to category 2 in that case?
That's a good question. Sam, you look like you might have thought since you came
Yeah.
up.
I kind of just want an example. Can you give us an example, Julian, of like how that would happen, what that would look like?
Can I do it maybe actually via email on how? Okay. That might be.
Is that an issue for others as well, or would they have a hard time distinguishing between performance payments not part of a risk arrangement and those part of a risk arrangement? Okay. UHA has no concern. Okay. Okay. Yeah, why don't you send us that via email, Julianne, and then maybe we can include some sort of language in the manual that explains what to do in that sort of situation.
That'd be great. Thanks.
Yeah. Okay. Okay. Next slide, I'm going to hand it over to Yishan, who I believe is on the next couple slides.
Sure. Thanks, Margaret. Hi, I'm Yishan Song, data analyst with Cosmos Target Program, and I'm just going to give a few updates we are planning to do for the CGT data submission manual and template. So first, we will update the provider taxonomy table to clarify that the physician assistant is, we will change that to the physician associate. It is based on the Oregon House Bill 4010. The act changed the term physician assistant to the physician associate. We will also add a requirement that when a resubmission is made, an authorized assigner must reapprove the submission. We will add the language in the manual and also make some changes in the cover page of the template to make sure the authorized assigner validate the numbers before they resubmit the data. We will also add the language described in medical pharmacy tab validation checks. So we start collecting medical pharmacy data last year, and we already have some language describing how to report this medical pharmacy in the manual, but we don't really have the language about what the validation process is for the medical pharmacy data. So we are going to add more language about that part in the validation process sections in the manual. Something like medical pharmacy is a subset of the TME Prof and TME on attribute tab. We will also add the validation checks in the template, just like what we do for other TME tabs. We will also add the language describing additional attribution validation checks. So we will add like more checks about the changes in member months and maybe the PMPM across years for the CGT's accountable provider organizations. We will describe this also in the validation process in the manual. This year we had a few resubmission occurred after we did a validation meetings with the provider organizations, the good things that these validation meetings were, but we recognize that it would be better if we can catch these errors maybe earlier, like in the pair data validation process. So we will add more language and in the manual for this validation process section. And we will add language to clarify that the residence for the member months through student plans for the Oregon University should be Oregon, regardless of the student's permanent address. So which means if a student has a health plan through the universities in the Oregon, we want to include their member months and dollars in our data. And next slide, please. So for the data submission template, first one, we will add the validation checks for the medical pharmacy tabs, which I already mentioned in the previous slide, just to make sure the medical pharmacy is a subset of the TME Prof and TME on attribute tab. We will incorporate the IPA and contract name field into the Prof ID versus TME Prof tab as a validation check. So we will add that in the template, which will be very similar, like what we are doing for the provider organization names between these two tabs to make sure the IPA name in the TME Prof tab is also in the Prof ID tab. Next one will be we will update the uninsured to self-insured in the final questions on the cover page. And the last one will be we will add additional fields for the authorized signature, which may include a space for a printed name or signature, and title of the signer, email, contact information for the signer, and the attestation that they have the authority to sign off. So that's all the proposed updates we are going to make for this data cycle. I think we can go to the next slide. And I will pass it back to Margaret to close this out.
Thanks, Ishan. Does anyone have any questions on those last couple of slides or thoughts, or just overall, you know, are there any updates that we didn't include in our list for this year that you think should be included or clarified? Yeah, just generally any final thoughts about any of these ideas? Okay. Well, you of course have our contact if you do think of something after the meeting, or if you're going over the list and yeah, think of something you want to communicate. I did post the slides on our TAG website this morning, so the slides should be on, it'll show up in the meeting archive for the TAG page. And you can go back and review the whole list if you so desire, or share it with others who couldn't make it today. Okay, next slide. Okay, so this is the second main update change discussion that we're going to have today. This last one was the CGT1 cost growth data, and then this year we're going to have our second round ever of collecting data on frontline worker costs from provider organizations. We did kind of go over some of the feedback during our last meeting, or some of the lessons learned, I suppose, and issues that we encountered in that data submission, which was our first round. This is just a recap of a slide that we had from last time. So some of the common reasons for CGT4 resubmission this year included did not follow specifications, submitted fiscal year instead of calendar year, submitted data for incorrect years, missing data of various sorts, total operating expense didn't include total compensation, direct care contract workers not included in totals, missing expenses, etc. We also had some errors where the data on the cover page didn't match the totals in the detail tabs, which I think was actually potentially related to some underlying template errors that we are hoping to prevent and not have happen this year, so we don't have to issue more than one version of this template. So yeah, that was just a recap of all of the reasons that we had for resubmission this year. Even though that's like, you know, a list with a number of different things on it, I think it actually went fairly smoothly considering it was the first year's submission. It is, of course, a fairly simple data submission if you're not doing the detail tabs as well. So we have between last meeting and this meeting updated the template. So I just have a couple of screenshots to share. I can go over the changes that we incorporated, mostly to kind of address some of these issues that we had during the first round of submissions. So now you can go to the next slide. Okay, so this is a screenshot of the updated contents page for the workforce data submission. A couple of the main changes basically are that we added a data validation tab, which I'll show some screenshots of in a minute. And then we also added a CGT4 submission schedule, along with a little bit of language about who is a mandated reporter for the program. This is fairly straightforward, but do any of the provider orgs present have any questions? Okay, next slide. Yeah, so cover page updates, a lot of these were just kind of clarifications and then little bits added to try to help the data submitters know what goes in the various categories. So we added a clarification that the data should be for calendar years, not fiscal years if your fiscal years are different from calendar years. And then we also changed, previously this template said previous year and current year, and we thought that might have been like a little bit confusing. So we changed it just to year 1 and year 2 of the data submission period. And then we also added numbers for the tables just to make them a little bit easier to refer to if we're going back and forth about something. The other big change is that for most of the fields now, there's going to be formulas entered in there. So those formulas will be pulling in the data from the subpages so that if you do fill out the detailed pages of workforce and frontline workforce and non-frontline workforce workers data, you know, which is a lot more of a detailed data submission. But if you do fill out those tabs, it'll just sort of automatically feed up to the cover page, and then you don't have to do that yourself. Most of you probably who are going to be submitting this will not fill out the detail tab based on our experience this year, which is fine. In that case, you can just override the formulas in the cells and put in numbers directly. Anyone have questions on these updates? Okay, next slide. Yeah, so then one of the bigger changes is that we added a data validation tab. The two main checks that are going to be applicable for people filling out the cover page only are just a basic check that total compensation is less than total operating costs, because total compensation is supposed to be a subset of total operating costs. I think we did have at least one data submitter who submitted the total operating costs as all operating costs besides compensation, but it's supposed to be inclusive of that. So you'll be able to look at this tab and just make sure that that's correct before you submit it. Same thing with frontline worker compensation being less than total compensation. So we'll just have a basic check that that amount on the cover page is less than the total compensation. And it'll flag with some red text if it's not. So fairly straightforward, but hopefully it'll be helpful. any questions on this part of the data validation tab? Okay. Next slide, please. Okay, so then we did include a little bit of a validation check as well for the detail tabs. If you don't fill out the detail tabs, this will just be blank. But essentially, this table just shows summary data for the total compensation and approximate FTE based on your payroll hours submitted for each of the subcategories. So basically breaks things down a little bit more. And so, our hope is that you can kind of look at those summary data figures and see, does that make sense to me? Is there something sticking out that just like looks off, and that might be able to help you flag something that you need to go back and fix in the subtabs. The blue columns do have an additional check. So this is for the frontline worker detail tabs. It's going to calculate an average annual compensation for anyone who is in the frontline worker tab based on the total frontline worker compensation divided by the approximate FTE. And then if that average annual compensation figure is less than or is rather more than the threshold that we have. So for 2023, this data submission this year will be for 2023 to 2024. So if it's greater than 200,000 for 2023, it will flag that you might have some non-frontline workers who are included in there. If it's greater than, I believe the updated figure for 2024 is 205,000. If it's greater than 205,000 for the year 2, it'll flag that as well. So hopefully that'll be useful for just keeping in mind that definition of frontline worker as was put in the legislation that created this data submission. Does anyone have any questions on this? And then there's going to be a similar tab or similar table for non-frontline workers that also breaks it out by sort of subcategory, but I didn't include that in here because it looks fairly similar to this one. There's also a column in there that'll flag in a couple of cases if there's anyone entered in the, I believe there's a few categories in there where it specifies that the compensation has to be over the threshold. So it'll specify any cases where the average compensation is actually under it. Okay, next slide, please. And then this is just a list of all the other sort of small updates that we made to the template that I didn't include a screenshot of. We clarified some language on the cover page and 2 questions asking about CGT TIMs. We corrected formulas calculating totals on the frontline worker tabs, which was an issue in the template last year. We added the CPI adjusted frontline worker total compensation threshold for 2024 to tab 7, which has a table with those calculations in it. There was some wording in the rows in tabs 4 through 5 that was previously referencing the $200,000 total compensation threshold. And since that is now no longer applicable to both years of the period, we just changed that to reference the thresholds in tab 7. And then we added a couple of FAQs around contracted labor expenses and data rounding or estimation. Next slide, please. Okay. Do any of the provider organizations on the call have any other questions on the list of updates or any updates that you would suggest in additional to what we came up with? Okay, hearing none. Obviously, of course, you can write to us at healthcarecosttarget@oha.oregon.gov if you do think of anything Next slide, please, Annette. So we got through material even faster than last time, I think, even though we had a 2-hour time blocked off today. So you got an hour of your day back. Congratulations. The next meeting is going to be April 23rd. Next slide, please. And the focus of that will be on, we will, as I mentioned earlier, we'll have made updates to the CGT4, or rather the CGT1 template and the CGT2 data manual, and we'll share that with you before the meeting. So the meeting will primarily just be going through those unless we come up with other agenda items that we'll communicate ahead of time. And then you should also just be expecting sometime in April, those of you who are mandatory data submitters will get your official notification that you are again a mandatory data submitter this year. And any provider organizations who are being required to submit the CGT4 template will also receive a notification of that this year in April. So that's all I got for you today. I hope everyone has a good day, and if you're in Portland, enjoy the nice weather as long as it lasts for another couple hours, I think. Okay, thanks everyone. Have a good day.
Thank you.
Thank you.